Welcome to Gloria's Gap Live. I am really excited today because I have one of my favorite people, my doctor, Dr. Hernando Chong. And I say his middle name because his dad was a doctor with the same name. So we have to distinguish. So we're going to talk about a lot of medical things that are of interest to me and to most of you. Everything from weight loss to just preventative health care. So thank you so much for coming, Dr.
Thank
Chong.
you for inviting me, Gloria. I know it's been a while. You've been trying to get me over here. And
we have talked about it for goodness, probably a year. Anyway, before we start, though, we have to thank South Florida PBS. South Florida PBS sponsors our show week after week. And if you are a fan of Marie Antoinette, season 2 has just started. So you'll want to check in on that. And through the end of this month, the Da Vinci Immersive Art Experience, if you haven't done it, it's like amazing. And Da Vinci was such a genius and so forward-thinking and visionary. And this immersive art experience is in Boynton Beach, and I don't know, thousands of school kids have seen it already, but there are adults like me who have gone again and again because every time you go, there's something new to see. And there's interactive experiences there too that are really fun. Anyway, so let's start. A little bit about your background. You started out at Nova?
yes, well,
no.
I met my wife down here at University of Miami.
Oh, you
That
did?
was,
Okay.
ages ago. But so I went to undergrad at University of Miami. I went to medical school up at Nova Southeastern University, which is up in Davie. And then I did internship and residency in the North Broward Hospital District, all up in Broward.
Right.
Worked up there for a few years and then moved down here to Miami.
And I inherited you from my husband's previous doctor, so we were so happy. And my husband loved you.
I remember your
Yeah.
husband well, and it was always a pleasure to take care of him, and you as
Yeah.
well. I'm
Thanks. Well,
always
yeah.
happy when I see you come
He
into the
spends-
office.
Yeah. You spend way too much time with me, I'm sure. We were just talking about that. How do physicians nowadays, because there's so much that you have to document, and we're saying that, for all of you that have doctor's appointments that are late, you can royally screw up a doctor's day. And I get morning appointments, and I have never had to wait ever. But at the end of the day, that happens.
Yeah, it's tough to run on time. You never know who's going to come in right before maybe your next patient's appointment,
Right.
and we do our best to address people's problems. But somebody comes in with one issue, no problem, right? Someone comes in with 20 issues. You do your best to address the most important things, but again, you never know when someone's going to have a complication or where you have to organize more studies or organize referrals for a person, and those things kind of take time. So, I try to be on time to work. I try to start on time. I try to, take my time with patients. But one of the things that's been a little hard is dealing with the electronic medical record system. Sometimes they're a little cumbersome or difficult to use. And a lot of physicians like myself, we employ a scribe who
Right.
really can help you move through your day because you have to document, number one,
Yeah.
right? I mean, number two, I guess. You want to take care of patients, number one.
Right.
But the
then
documentation is
yeah.
important. So
Yeah.
so that takes a little while. It's been a hurdle for us.
So, but you have an amazing staff.
Oh, thank you.
He's, Dr. Chong is MD's in South Florida is right, not too like blocks from Baptist Hospital. in
Right, we're
Kendall.
right across from
Yeah, so
the
it's
Miami
really
Cancer
handy.
Institute. Right
Yeah.
there. We're in that Baptist
Miami Heart
catchment area.
Institute, yeah, and Miami Cancer Institute,
Right.
yeah, everything is like in that little area. It's great. So we were, you and I had talked about because I know you tried to, start a weight loss kind of division or whatever. And it didn't pan out because one of the reasons, because even though it's so important to for people to maintain a good weight, insurances don't cover it.
Right, it's hard
that's
to
an
get.
issue.
It's hard to get insurances to cover certain obesity treatments. The new medications, which are unbelievable for weight reduction and treating obesity and overweight, they are quite expensive, and so it's getting
And they're
really
not
hard.
covered
And they're
unless you're what, diabetic or
well, right. So some of the medicines were initially intended to treat diabetes, and then of course, when we're treating a lot of those core defects related to diabetes and metabolic disorders, weight loss was a very well-known side effect. And so the medicines were studied specifically for treatment of obesity and overweight, especially in people with comorbid conditions.
Mhm.
And they've been really successful. But when I was starting out as a physician, I didn't want to be the doctor that was prescribing 20 things for 20 problems. And, I realized the root of the problem was really part of our diet, our lifestyle. And I thought, where can I get educated as far as how to treat people for one of the underlying problems rather than the comorbid problems related to obesity? So I became a diplomat. I got board certified in obesity medicine through the American Board of Obesity Medicine.
I didn't even know there was such a thing.
Yeah, there is. Now, I guess one of the complications is for years, obesity really hasn't been considered a disease like you could say diabetes or hypertension, but it's all related to that underlying cause. So then I started really focusing on lifestyle changes. How can you use food as a medicine? How can you change habits? How can you promote healthy lifestyle and healthy living? Actually, my obesity company was called Healthy Living Weight Loss.
Mm-hmm.
So we did use other modalities like meal replacements. Phentermine was a medication that we used quite a bit.
Phentermine? Never heard of that.
Phentermine, yeah, it's a weight loss medication that's been used for decades and decades. But the new medicines that are out, semaglutide, tirzepatide, which are dedicated GLP-1s that can help you with weight loss, they're much more effective. And there's a lot of people out there specifically asking for those medications.
And are those expensive?
They're if you were to pay cash, they could range you about $1,000 a month.
Ooh.
Which of course, when you try to get an insurance company to pay for that, there's a lot. Yeah. Even for diabetes, we could hire 20 people just to do the prior authorizations to get those medicines covered for diabetics.
Mm-hmm.
But there's patients who do, they will go out and they'll pay for it. The companies that produce it now have some programs for patients who want to pay cash, who can't get it through their insurance companies. And there are some insurance companies through their employers who do have obesity benefits, but they're not a lot. But we always ask our patients, please find out from your HR company through your insurance, would these medicines be covered? And we're happy to write them for you if the indication's right.
Yeah. So lifestyle, you tell people, okay, exercise, eat the right stuff, low carbs, low in the bad carbs. Yeah, right. Yeah.
So that, that's an uphill battle too, because when I first start coaching people what healthy eating is or what healthy exercise is, it's an uphill battle because people have been taught what healthy eating is for so many years, and fat's been vilified, and really a lot of the underlying problem is sugar, because sugar raises insulin levels. Insulin, that's a pro-storage hormone. There's some inflammatory issues with high insulin levels. Sugar itself can be toxic to your body. Mm-hmm. And we know diabetes, right? Diabetes is a huge cardiac risk factor, and there's a lot of things diabetes does to your body, from blindness, amputations, vascular problems, kidney failure. So we know that sugar itself can be an issue. But
and isn't it on the rise? Diabetes?
Diabetes, obesity. I mean, the data out there is staggering as far as how many states.
And how much, you'd think that what it ultimately costs insurance companies when you've got people with all the side effects of diabetes and obesity.
Yeah.
I mean, even your knees, people not being able to walk because they're just so heavy, their poor knees can't.
Absolutely. There's weight loss companies all over the U.S. that are non-surgical orthopedics, and really they get people to drop weight. Imagine if I asked you to go put on a 50, 60, 70 pound rucking vest and go do all your normal activities, you're going to come back home, take that thing off and go, what a relief. Right. So yeah, people are out there carrying a lot of extra weight and causes a lot of back, knee, hip problems.
What is the ratio? I know that, for every pound that you gain, there's so many more pounds that you put on your extra.
I can't tell you. I can't tell you the physics on what kind of pressure you're putting on your knees.
For every pound, it's like 5 pounds, but so many more pounds that you're putting stress on your body,
on your joints.
Yeah, right.
I can't tell you though that
we'll have to Google it.
Yeah, right. That's the next thing on the list for sure. If I had my scribe here, she'd be looking it up already. And she'd give me the
doctor,
stats on that right away.
Yeah, right.
But yeah, we've seen a lot of success in people, even people who are about to go for a joint replacement and they need to lose weight. We'll put them on, treatment. We've had people very successful. And then of course, when you have your knee replacement and you're 30, 40, 50 pounds lighter, your rehab is easier and your recovery is a lot easier. So,
and then some people get the knee replacement and then have to do it again. And what?
Oh, you mean how long the knee replacement lasts?
Yeah.
Or,
how long do they last?
They say like 10, 15 years.
Oh, yeah.
Yeah. But
there's, but whether they gain weight or not.
Right. But for sure, we have people learning how to exercise. I'm a big believer in resistance training, not necessarily resistance to get bulky and big.
Like doing
more, I have
kind of
I have patients who go out for a long walk, let's say, and you're not really putting on a lot of muscle. You're not really burning a whole lot of calories, the amount that you think going out on an hour-long walk.
Yeah.
But it does take an hour to do that. So I ask people to incorporate a little resistance training. Take a resistance band, those little ropes with the handles on the ends.
I have them all.
Yeah. And so they're really lightweight. You walk with them and every 5 minutes you stop, you do some kind of resistance thing. And it's again, not to bulk up and look like you've been in the gym for 5 hours, but to develop healthy muscle. Mm-hmm. It's healthy muscle that burns calories more efficiently.
Right. The more muscles you have, the quick.
It increases your basal metabolic rate. Right. And it's also healthy. You can burn glucose efficiently. You store a lot of sugar in your muscles. And for people who want to have more indulgences, let's say, the more healthy your muscle are, the more tolerances you have for, let's say, dietary indiscretions, or if you want to eat more sugar in your diet.
That's like having dessert.
Right. Exactly. You want that dessert? You better walk after.
That dietary discretion.
Right.
I like that. That's a good one. Oh, I think I'm going to need to take advantage of this.
So it can be an uphill battle trying to let patients know that there are healthy fats to eat. There's essential fatty acids out there your body can't make, like essential amino acids, and you have to eat protein.
Okay, as far as fats, what are good fats to eat? I hear about avocado.
Yeah.
It's like a good one. Is that right?
Yes. Now,
yes and no. I mean, it's fattening too.
Yes. No. I cannot tell you. I cannot tell you how many times I have to tell people who are trying to drop weight that I don't really believe there's terribly bad fats. And now we know trans fatty acids, those are really not good for you. But saturated fat can sometimes raise people's LDL cholesterols, and we worry a lot about cholesterol, especially due to heart disease. But at the end of the day, if somebody's diabetic and I'm trying to decrease your risk factors for heart disease by controlling diabetes, then I'm not asking you to avoid really any kind of fat. But I'm okay with, animal fats. I'm okay with, plant fats, avocado, healthy medium chain triglycerides.
Right.
But also protein is really important in your diet. So if you're going to eat saturated fats that are associated with animal proteins, I'm okay with that. I have a lot of patients who they do ketogenic diets, paleo or carnivore diets, and some of them, their cholesterol goes up, some of them down. But at the end of the day, I see a lot of improvement in diabetes.
Okay, what's the best diet for cholesterol?
For cholesterol,
since he's taken me off statins.
Yeah. So,
and you're right, it's working. I don't have the muscle aches. Statin drugs really give you muscle aches.
There's a lot of, I can say, a variety of information out there on cholesterol lowering, whether or not it's important, statin therapy, who is promoting statins, how it's being marketed, what are the real effects and potential side effects, how the studies are done. But, the book tells you if you have a patient with coronary artery disease, your LDL goal is less than 70, and it's very difficult to do that with diet. Most of those patients need medication, and there are some other benefits said that statins are said to have, like anti-inflammatory properties, plaque stabilization. So heart attacks sometimes happen when a little plaque breaks off your coronary artery, and then there's not a lot of real estate for a clot, but your body perceives there's a little cut in the artery when the plaque breaks away, and so platelets aggregate, they cause you a heart attack. So statins are said to stabilize plaque. So I'm still there where I'm recommending statin therapy to lower LDL. I have a lot of patients who just refuse to be on statins, and we talk about shared decision making in medical practices now, and so we may agree to disagree, but I can't tell you that they're all dying of heart attacks, let's say, because they have coronary artery disease and they're not on statins. So, and people do their own research now. So it's difficult for me when a person's very interested in a particular subject. They've done hours more research than I've done on it. So they come in and they've got all this information. I'm like, get back to you on that, 'cause now I got to go do some more research.
No, you just need to share that information with me so I don't have to go look it up.
Right. And then, then people use statins for primary prevention. If someone has a lot of risk factors for the development, maybe a future development of coronary artery disease, we also, there's also a school of thought of putting patients on statins before they develop coronary artery disease. So, and then there's schools of thought that it might not be necessary. So it's
a toss up.
The waters are getting really muddy there.
I know.
But I can tell you that we do know that, again, diabetes, obesity, all those things, they have their own set of risk factors. So if I'm trying to quantify the risks of developing heart disease, which again, people die of heart disease, right?
Right. Yeah.
There's family history. You can't do anything about that. There's age. You can't do anything about that either. But there are modifiable risk factors like smoking and diabetes.
Right.
So there's hypertension you can treat. There's cholesterol you can treat. But those things are a little further down the line. So the lower hanging fruit is treat diabetes and obesity. And that's really where I try to focus a lot of my efforts.
Yeah. So now when people go into your office and they say, hey, we have issues here, do you counsel them? And I think you have like brochures and stuff, don't you? That you share?
Yes. So a long time ago when I started at studying for my board exams for obesity, there's a physician, Dr. Eric Westman, actually. And a long time ago, he said, here's my handout. Here's what I coach people to do. And I could sit there for an hour and go over those things with you, but he's already got it set up. So I refer patients to see what he did on YouTube and the handout that he had given out. And it's basically a lot of what I want to say, but as you know, our time's limited. But I do try to counsel patients on what I think healthy eating is, what I think healthy exercise is, give them an opportunity. I have them come back kind of soon, especially if there's a lot of metabolic stuff that you can see data-wise, if there's labs, if there's evidence of insulin resistance or prediabetes, or their triglycerides are very high, or they have elevated liver enzymes from fatty liver, or orthopedic problems or sleep apnea. All those things can get better with weight reduction with the proper lifestyle modification. So I do really take some time to coach people.
I hear so many people with sleep apnea and they have to wear those things at night and that kind of thing. What is that necessary to when people stop breathing?
Yes.
Are they going to wake themselves up because they've stopped breathing?
Some people do.
Has anybody ever died from not waking up from sleep apnea?
When your body senses that your oxygen... Yeah, I know. I can't tell you that if
you stop breathing, you go, hey, wait a minute.
Yeah, I can't tell you that someone has directly died from asphyxiation from obstructive sleep apnea. I don't think I've had a patient die, but I know that there's complications related to obstructive sleep apnea. Most notably is atrial fibrillation. So there's an arrhythmia that's highly associated with sleep apnea. So what ends up happening with sleep apnea is, when you go to sleep and you get into deep sleep, all the muscles in your body relax, including the muscles that hold your airway open. So the air has to snake down, and typically people snore or they get that really deep, low breathing. So at some point, when your body's completely catatonic, your airway gets cut off. And usually it's your tongue that lolls in the back of your airway and occludes your airway. So what happens? When you can't move, when you're in deep sleep, your brain has to wake you up to either light sleep or to full arousal so that you can start breathing again. Yeah. So if that pattern happens 100 times at night, it's putting a huge strain on your heart. And over time, that can, change the pressures in your heart, change the shape of your heart, and lead you to have certain arrhythmias like atrial fibrillation. And AFib is a big risk for strokes. And so if a person comes in and they were just diagnosed with AFib, one of the first things I do is I get them evaluated for sleep apnea. Now, it turns out that you don't have to be a really big person to have sleep apnea, but 10% total body weight loss can help sleep apnea by like 50%. So patients who go and they drop weight and they have sleep apnea, note that their snoring is less. I wouldn't encourage everyone to just get off of their CPAP machines because, that's what's protecting your airway when you're sleeping. It pushes air into your airway while you're sleeping to hold your airway open because there's no muscle tone there.
Right.
So, but people who have less, bullish necks and weight on them tend to snore less and sleep better. So actually, there's one of the weight loss medications that is now being approved for obstructive sleep apnea.
Oh, really?
Not because of the molecule itself, but because of the weight reduction. But that's another, prior authorization hurdle we primary care doctors are going to have to start dealing with. And
oh my God.
So, but if we have to go to bat for our patients to help them, because there's an indication for it, we will. But it's a struggle to get these things authorized.
So when you're going to bat with the insurance companies, so does the American Medical Association talk with the insurance companies and say, hey, listen, we need to address. Is there some kind of relationship that's going on? There should be.
It's more of, when a medication is approved by the FDA for a particular medical problem. I mean, we can use things off label. I can use anything off label as long as, doctors in my community would probably be doing the same thing. But once something's FDA approved doesn't mean that an insurance company is necessarily going to cover it.
Exactly.
And they may not cover it as a first, second, third tier, or they may need you to try other things before they cover it. So even Medicare, Medicaid, certain private insurance companies, they may or may not need to cover a particular medicine for whatever reason if there's certain generic alternatives that are available. So if there's an indication for someone to be on a medication, I may be able to argue, or not argue with an insurance, but submit to an insurance why I think that medicine may need to be covered. But it takes a lot of man hours to do that.
And I know I've heard of people saying, "Oh, I had to go through these generic things that didn't work before they would."
Right.
They
And
would
that
let me go for the real thing,
for the more expensive or branded medication that is FDA approved for that condition and is marketed to you when you're home at TV, watching TV. And of course, you got to ask your doctor about that purple pill.
I used to think, oh, that's terrible. They're marketing these drugs because, I think so many people are on way too much stuff.
Yeah.
Yeah. And that's what I love about you. You just
food is a medication.
Yeah.
That's where you got to start. Food is a medicine.
Right now, I don't think I'm on anything but a bunch of different vitamins.
Good. Right. Yeah. Great. You're super
statin
healthy.
Was my only one, but I may have to, maybe you can talk me into going back to a lower dose.
Yeah, we trial and error too.
Yeah, right. I know.
How things work out for you.
Yeah. So, what other conditions you find in your patients right now that contribute to, that could be corrected with preventative measures?
Well, as far as screening, we do a lot of primary care screening. There's always a list that we have our patients do from anywhere from colonoscopies at the right age. Oh, right. We also have patients who are adamantly against doing colonoscopy. So we try to find other things like.
And why are they against it? Because
there are some risks to having colonoscopies done. I mean,
if
there's
you don't have
sedation.
Doing it right.
Yeah, there's sedation. There's mechanical risks to, having a colonoscopy.
Yeah.
And there's fear. People are worried about prep. Back in the day, you have to.
Well, that's the only bad thing.
Well,
but it's not so bad anymore.
No, right. There's a lot easier
so
preps.
Much better. Yeah.
And
I remember
they changed
those gallon jugs.
Yeah.
Oh my
gallons
goodness.
Ago lightly, and you have to drink those things now.
No,
they have.
You weren't
tablets.
going lightly.
Yeah, no, you were going.
Which was like such
ironic.
Really?
Yeah. So now they have these little tablets that you can take, or these little bottles, and you chase it with water.
Yeah.
And our endoscopists are super well trained, and but there's
is that gastro health?
They
go through 100 people a day.
Yeah, that's a large group down here in South Florida.
Yeah, right.
And there's a lot of well trained GI docs, and as a primary care doc, we try to have a network of physicians that you can rely on, that you can pick up the phone and call, that you've had good experience with. And we always ask our patients, how was that with that doctor?
Oh, right.
What kind of feedback can you give us? How was the office? Was it easy to get in touch? How was the whole process? And those are the people that they start going up on your list of who you're going to, your referral basis. So, and that's what you want from your primary care doctor, is to be able to have a network of people that are reliable. And often patients come back and they're like, that office was great. And so we start referring more. But colonoscopies are real important. The recommendation was changed from 50 years of age to 45 years of age. I can tell you, even in my practice, had that recommendation not changed. Well, again, where do you draw the line? And I'm not a statistician.
Don't you think it depends on if you've got a family history?
Yes, absolutely. Yeah. So 40 is our cutoff for people with family history of first-degree relative with colon cancer. But when they changed from 50 to 45, I have patients who had that recommendation not been made, they'd have been living with a colon cancer undetected for years before, they hit 50.
Not? Yeah. And once you have, it's my understanding that once you have a polyp removed, they're going to come back.
Well, so if you have a clean colonoscopy without any significant risk factors, it's usually 10 years. If you have polyps, they'll bring you back anywhere between 3 and 5 years, depending on the type of polyp. Adenomatous polyps are a little riskier, I suppose. So they bring you back in 3 years or so. And hyperplastic polyps about 5 years. But if you have a number of polyps, they're going to want to see you again
every year,
pretty soon.
I have a friend of ours, a neighbor of ours growing up, that used to call it her colonoscopy and spa day. Because she would take the day off and she would, but she had a family history of it. So every year she had a colonoscopy. So,
So there are ways that, especially for screening, we can help our patients. Obviously there's blood work screening and weight screening, smoking, cessation. Vaping is really popular, especially in our youth.
So what are is that pretty much the same risk factors involved with regular smoking?
I'm sure there's going to be a lot more data coming out with, either lung cancer or, especially now, with the legalization of marijuana, are we going to be seeing more emphysema, COPD? What are the complications of actually smoking? And then there's complications of the actual pens that are being used, because there is a heating element in there, and we don't know what happens to the vapors as you're inhaling them. I imagine, just like when a medicine's out there for 20, 30 years, you start to, when the population who's using it is larger, you find more side effects.
I think some people were trying to get off of smoking, and then they went to vaping.
Right. And you're kind of trading one addiction for another.
I just had a friend that just said she's off it altogether. And I don't know what caused it. Maybe there was a cancer scare or something that made her say, hey, let's just stop. And she said, I feel so much better.
Yeah. When a patient comes in and they smoke, the first thing is, are you ready to quit? Because if you're not ready to quit,
they're not going to quit.
But I do offer all kinds of different modalities to try and quit smoking. There's a medicine called Chantix, which by far is probably one of the most successful ways of smoking cessation. But anywhere from, cold turkey or
that's what
cognitive
John did,
behavioral
remember?
therapy. Yeah.
My husband just one day said, I'm not walking across the street. It's 100 degrees out there to get a pack of cigarettes. I quit.
Yeah.
It was as easy. But he used to have nightmares, about that he started again. I could never quit again. If I started again, I could never quit again. It was that hard.
And sometimes it takes people 5, 6, 7, 12 times to quit, but every time you quit, you're smoking less, right? And so we do encourage people to find something else to do. Switch a habit, to switch it to something healthier. There's nicotine patches, there's lozenges,
just chewing
there's
gum.
Acupuncture,
John
whatever you want to do.
A lot. After when he was quitting, it was like something to do with your mouth.
Right. There's an oral fixation or something.
Right. Who knows?
And some people just make associations with, I'm going to have my first cup of coffee and have a cigarette, or I'm going to drive to work. And so we tell people, well, start using your fork in your left hand, or, don't have that cup of coffee here, drive a different way to work, or throw the smokes in your trunk inside of a plastic bag wrapped in foil, and have more hurdles. And the same thing with certain foods. If you have a craving for something, delay that craving a minute. Every time you feed into something, you're just feeding that limbic pleasure center thing.
With regard to that, I remember somebody told me, instead of, sometimes you want to have something sweet after a meal, just go brush your teeth. And I go, What a great idea.
That's a
So I
big
started
strategy.
putting a toothbrush downstairs so I wouldn't have to go upstairs to brush my teeth.
Yeah, there's first a now it's minty in your mouth and you may not want something else, but
Exactly.
also there's a psychology to I'm done. I'm brushing my teeth. That's it. No more
Well,
food.
Exactly. Oh, and then if I put my retainer in, then I'm really done.
Then forget it. And there's nothing else going in. So there's a lot of strategies that we use for
That's great.
patients,
That's great. Well, it is such a pleasure having you as my doctor. I feel very protected by you. So thank you for everything you do and for all your patients and for coming and being on the show and sharing your knowledge with us. I appreciate
I'm
that.
super happy to have been here.
Yeah,
Thank you so
have to
much
come
for
back
the
again
invitation.
sometime.
Absolutely.
Yeah. Okay.
Thank you.
Our time is up, believe it or not.
Oh, okay. Oh, wow.
30 minutes went by like that.
Super fast.
Yeah,
Thanks
really.
so much, Gloria. It was great to be here.
Well, I appreciate your coming. Again, thank you, South Florida PBS, for sponsoring our show week after week. And for all those tuning in today, hope you have a great week. Be kind, make a difference, and have a safe week. And
Thank you so
happy
much.
Weekend. Okay.
Appreciate it.
Thanks for coming.
All right, Gloria.